Okay, I'm going to introduce Dr. Camille Hirons now. She's going to give you a 15-minute talk about her experiences of lifestyle medicine group clinics. Camille, over to you.
Thank you for having me. I can't believe I already had tech issues, but can you hear me okay without my
We
headphones
can,
in?
yes.
Fabulous. Apologies if there's any background noise. You might be able to tell I'm sat in a stairwell because it's the only place I could find. But let me know if you can't see your slides. If you can't see them. But it's a real pleasure to be here. So thank you, Georgina and Alicia, for asking me to come and talk about how we've integrated group clinics into our integrated neighbourhood teams and lifestyle medicine. I'm Camille. If I don't know any of you, I'm an NHS GP in Lewisham, South East London. I'm the clinical lead for integrated neighbourhood teams. I'm also a certified lifestyle medicine physician and a fellow and the vice president of the British Society of Lifestyle Medicine. So I've only got 15 minutes and I could talk about this topic for hours and hours and hours. But in summary, with regards to integrated neighbourhood teams, we're focusing on three main areas. One is multiple long-term conditions, one is frailty, and one is children and young people. And the model I'm going to talk you through today is focusing on multiple long-term conditions. Now, before we do that, I do think it's really important to have a good understanding of what we mean by health inequalities, because the theme that links all of these different INT kind of themes are reducing health inequalities. So NHS England have developed a way of helping us to identify people at risk of health inequalities called the Core 20 plus 5. Now, the Core 20 refers to the people, the 20% of the population who are most deprived, and that's based on the indices of multiple deprivation. But then the plus groups refers to additional people who might be at further risk of health inequalities. So they might be disadvantaged by their socioeconomic status, like income, education. They might be disadvantaged by things like geography or age or ethnicity, or they might be disadvantaged because they fall within what we call inclusion health groups. So they might be experiencing homelessness, they may have a learning disability, or be an asylum seeker, as an example. And so that's the Core 20 plus. And the five are these five clinical key areas that we need to work on nationally to help reduce health inequalities. Now, I just thought that was important as I set the scene for Lewisham. Now, I love Lewisham. Lewisham is amazing. It's vibrant and diverse, and it's in South East London. Now, we have a population of 300,000, and of those 300,000, 67% of our population fall within the Core 20 plus. So just to set the scene with regards to health inequalities, we have a lot of diversity, with almost half of our population being non-white. Half of our population don't speak English as a first language. We have a housing crisis, with the council referring themselves to the housing ombudsman because of the huge wait for temporary accommodation. So just to paint a bit of the scene. And so when we were designing our integrated neighbourhood teams on multiple long-term conditions, we knew it was really important, based on a lot of the health inequalities work we'd already done, to co-design and co-produce parts of this. Because what we see all too often, and I'm sure a lot of you can relate to this, are these top-down decisions within our national health system. Whereas if we really want to reach underserved communities, help reach the people we want, we need their help in designing it. There are some videos on YouTube if you want to find out a bit more about how we co-designed our integrated neighbourhood teams, but I won't have time today to go into depth with it. However, just to give you a flavour of what we're trying to do, we're focusing on 3+ long-term conditions, and there's a long list that we're allowed to incorporate. But we knew we'd have the biggest impact on health inequalities if we started with cardiovascular disease. So these are the 4 conditions we're using, and handily you can remember A, B, C, D: atrial fibrillation, hypertension, chronic kidney disease, and diabetes. This also helps align to the King's Health Fund, which shows that the biggest way to reduce health inequalities is to start with cardiovascular disease. So across our population, there are 4,000 people who have 3 or more of these 4 conditions. Now, we have developed some specific roles with regards to integrated neighbourhood teams to help deliver this work. So very quickly, we have a caseworker. The caseworker does a very holistic assessment I'm going to talk you through. We have the clinician, who are clinical pharmacists with their scope of practice being around cardiovascular disease. We have our community link worker who helps with an asset-based community development approach. And they also help with linking those community groups, a bit like social prescriber would do as well. We have our key worker who really, that's support for the most vulnerable people. And it's kind of, I describe it as social prescribing plus a lot of navigation, advocacy and social prescribing. And finally, our health and wellbeing coaches who deliver our lifestyle medicine service, which I will come on to shortly. Now, where you can see the stars, hopefully you can see that, the health and wellbeing coaches, the caseworker and the pharmacist, those are the roles who are helping deliver our group clinics and our lifestyle medicine group clinics as well. So Alicia's going to go into a bit more detail later on group clinics and how to do them, but very, very quickly, they are basically a shared medical appointment. And usually it would be up to around 12 people, but because we are dealing with very complicated and vulnerable individuals, we have slightly smaller groups, so around 8 people. And the appointment is 90 minutes long, so it's a long appointment. Now there's shared learning, there's peer support, but don't forget that it's not just education. In this group, every individual has a one-to-one consultation. And so they will leave that group with their own personalized care plan. And that's really important not to forget. Now, Georgina and Alicia can share realms of evidence with regards to group clinics and why we should do them. But here are some of the key things. It increases your clinical time. Now, in primary care, I have 10 to 15 minutes with a patient, but with a group clinic, I will have up to an hour or an hour and a half. So it's so much longer. You get peer support, peer learning. It's far more efficient. I also get a bit frustrated as an individual repeating myself with every patient, how to reduce lipids, improve their blood pressure management, etc. In a group, I can do that once and I can do it really well. There's evidence even of better clinical outcomes. It can help with access and it can also help around communication. And the lovely bit is patients and staff really enjoy that. And I can agree that that's some of the feedback we're starting to see already in Lewisham, even though we haven't been doing it too long. Now, there are different roles, and again, Alicia will probably go into this a bit more. We have a facilitator. They are the magic. They have to hold this whole group together. They do the welcoming, they gather the right questions from the right people, make sure that introverted voices are able to have their say. The admin role is really important as well, helping book patients in. It could help with documentation, the results board and so on. And then the clinician. And the clinician comes in, not actually for the whole consultation. Usually it would be about an hour's worth of that 90-minute to do the clinical stuff and the medical optimization of those conditions. Now, with regards to our integrated neighbourhood teams, we're able to use groups in 2 different places, and that makes me very happy. So we originally, if we start on the left, have this getting to know you holistic assessment that's done by our caseworkers. We then move along and have straight away our group clinics, and they're run by all the team that I said, and that's our medical optimization of all of those long-term conditions. We then have our lifestyle medicine service. We have a getting to know you assessment follow-up, and then they are discharged with patient-initiated follow-up. So I haven't got very long left, but it is really important that I kind of just delve into a bit more lifestyle medicine, because this is where we're also incorporating some group work. So for anyone that doesn't know, and it was really nice to see that quite a few of you already do know lots about lifestyle medicine, but lifestyle medicine is an evidence-based medical specialty, and the evidence shows that we can prevent, we can treat, and we can sometimes reverse long-term conditions or chronic diseases. Now, the way it does this is it supports people to make behaviour change focused on these 6 pillars that you can see on the right-hand side of the screen. So it's food, physical activity, restorative sleep, mental well-being, social connection, and reduction in risky behaviours. Which isn't just smoking, drugs and alcohol. It might be things like smartphone addiction and so on. And the thing I love about lifestyle medicine is it meets people where they are. It acknowledges those wider and social determinants of health. But to put it simply, we're trying to deal with the root cause of disease, because as a GP, I can feel frustrated that I'm often dealing with the symptoms of a condition rather than the underlying cause. So I can't put it better than this. We need to stop pulling people out of the river and move upstream and find out why they're falling in the first place. So very quickly, if you don't know about lifestyle medicine, just a few other bits to help and convince you, and hopefully want you to find out more. But the World Health Organization in 2023 found that non-communicable diseases, diseases that aren't contagious, are responsible for 74% of all the deaths globally. And 80% of those premature NCD deaths are at least partly attributable to 3 risk factors alone. That's smoking, poor diet, and lack of physical activity. And what we all know is they are very strongly linked with socio-economic inequalities. So as well as dying younger, we also have a worse quality of life and health-related quality of life. So I would love us as a health system to focus more on health span rather than lifespan alone, because we know we can live around 63 years in relatively good health span, but then we can live up to 19 years with a poor quality of life, loss of independence, multiple conditions, and that's really where we need to focus. So very quickly, the journey with our lifestyle medicine service again began with co-design. And the themes that you can see on the right are what the community told me they wanted the service to look like. So they wanted it holistic. They didn't want it run by a doctor. They wanted it non-clinical. They wanted it open to everyone in our primary care network in the north of Lewisham. And they already told me, this is 4 years ago, that they wanted group working because they saw the benefit of that peer support and peer learning. And so our original lifestyle medicine service was born. So it's run entirely by health and wellbeing coaches, some of which are also trained as nutritionists. And they will offer one-to-one coaching sessions where they'll work through any personalized goal. And then these group sessions where they go through all 6 pillars of lifestyle medicine, because what we're trying to get is a balance across all 6 pillars. Our service remains open to everyone, although we do purposefully invite people with cardiovascular disease and underserved communities through a lot of community outreach. The service is around 12 weeks long, and we have the benefit of working within our primary care networks like MDT Working, being able to discuss and share cases with people like our social prescribers. So just to share some of the data with you. Now, the first thing I want to point out, I hear a lot, isn't lifestyle medicine just for the worried well and the wealthy? It's about wearables and supplements. No, absolutely not. We're talking about getting the basics right for everyone. And 75% of the people that come through our service, this is data for 133, they fell within that core 20 plus, and 79% were of non-white ethnicity. So I'm confident that through those approaches we've adopted, we are getting the right people into our service. Now, what you can see on the screen, the orange is before our intervention and the green is after our lifestyle medicine service. Essentially, we saw statistically significant improvements across every pillar in lifestyle medicine. So people slept better, they felt more connected, improvements in mental health, physical activity, and fruit and veg as a proxy for nutrition. But my favourite is that people felt it more control of their own health, which can have a huge benefit on the health system as a whole. We did decide to take a slightly more flexible and culturally appropriate approach for our patients living with diabetes, because they were some of our most vulnerable in the primary care network. So again, covering all 6 pillars of lifestyle medicine, but more visual aids and flexibility. And it's about connection rather than perfection. And actually, our coach Nana, her results speak for themselves. A much smaller data set, this is data for 65 patients in total. But for pre-diabetes, we had an average reduction of 4 millimoles, which is sustained at 6-month follow-up. But for diabetes, we had a reduction in 22 millimoles at 3 months, which was increased to 35 at 6 months. And 32% of her patients are no longer living with diabetes, and 62% are no longer living in that pre-diabetic threshold. So we continue to evaluate. I've now got data for about 80 patients, and the data looks very similar to this, which is really exciting. And just to highlight the vulnerability of some of these cases, because Rohan was one of the cases I sent to Nana, and he's a 72-year-old asylum seeker with a HbA1c of 95. He didn't speak English, he had hearing difficulties and huge issues around his initial accommodation centre, the hotel. Now, he attended with his wife, and Nana used an interpreter and lots of visual aids. And his HbA1c went from 95 to 59. And an unintended consequence is that his wife's HbA1c went from 44 to 40, which is really exciting. I know I'm running out of time, so I'm trying to wrap up as quick as I can. But essentially, patients, they really enjoy this service. I actually don't have any negative comments, which is really exciting. And if you can see, so that people will repeatedly tell us that the groups are some of their favorite part of this service. Now, what's really lucky with our integrated neighbourhood teams is that we really wanted to replicate that lifestyle medicine approach. So we've lifted and shifted our North Lewisham model and now have the exact same thing across all 7 primary care networks for our integrated neighbourhood team patients. So those complex patients with 3+ long-term conditions. And actually, this is hot off the press, our first data, looking at 56 patients. There's a lot of information on the screen, but what I want to highlight is statistically significant improvements, again, in all the pillars of lifestyle medicine, statistically significant improvements in validated well-being scores, and statistically significant improvements in some biometric markers like systolic blood pressure, weight, BMI, waist circumference, and HbA1c. So I've done my best to summarise quite a complex lot of information into 15 minutes, and I hope that's been helpful. If you do want to learn more, there are some resources on the screen, including you can get 50% off BSLM membership if that is interesting to anyone. So thank you very much for having me today, and I'm going to try and stop sharing now.
So I'm going to feed some questions to you, Camille, that we've got from the chat. So and a lot of them are clarifying sort of some aspects of your model. So the first one is, do the groups just get one group clinic or several? That's from Sarah. And Sarah also asked, do you have enough time to go through their clinical results in the group? Because obviously they are complex patients. So,
Yeah.
you know, sort of just a little bit about how that works.
Yeah.
And I know that's probably why you chose to have a smaller number of people in the group as well.
Yeah, absolutely. And it's a really good question. I mean, I could have talked just about our group clinics in INT for a very, very long time. And so I did my best to do it shortly. To summarise, yes, we actually offer 3 group clinics for our integrated neighbourhood teams because they are complex and we're trying to medically optimise those 4 conditions. So they have 3. The other thing that we do is, yes, we do have time to go through everyone's individual results. We have a results board I think Alicia's going to come on to later, or maybe Georgina. And we get that up every session so that people can see where they're at, they can compare and contrast, and they can also celebrate improvements, which is really, really nice. So yes, we go through all of the results within all of those groups, and they have 3.
I think another thing to just add to that, just from a practical point of view, because I know, you know, when we did your dry run at your training day, I think what is also really apparent is, you know, you can't ask patients to change everything all at once, can you? And even as a clinician, you're not going to be changing all of their medication right very suddenly. You're going to be changing probably one medication at a time. So I think the other thing is that you want, you know, you kind of you are quite focused on what you want to talk to each patient about. You establish that beforehand, because we can't overwhelm patients by talking about absolutely everything. We might be reviewing absolutely everything, you know, if you like, from a clinical point of view, but do you want to say something about that? Is it a little bit of a balance? What have you found that works well around that? Because I think that's really useful learning for people who are doing group clinics already.
Yeah, absolutely. So yes, you can't do it all at once, and it's the same with behaviour change. You can't tell people to improve all 6 pillars of lifestyle medicine at once. We very much say pick one thing and let's work on that. And I would say it's really helpful to include just a couple of coaching questions within these groups, because you can say, well, I'm really worried about your HbA1c, your diabetes, but tell me, what's the most important thing to you right now? And that can transform the entire conversation with that one question. And then you can also get a balance between what they want to focus on and what you want them to focus on. I could see one of the questions was, how long do you have in between your groups? We space out the 3 groups over 3 months so that we can also see improvement in the HbA1c. And I think that they're about 6 weeks apart, yeah.
So that's those questions. Then we've also got, how did the teams get, how have your teams been trained in lifestyle medicine, and what training did non-clinical teams undertake? Non-clinical team members, sorry.
Yeah, so I have developed CPD accredited lifestyle medicine course, which all of our teams have had, including clinical teams and non-clinical staff. So for me, lifestyle medicine is two-pronged. It's education, so I would love everyone to know about it. And then we have the second prong where we have people actually delivering the service. So they have all had the same training, but then the people delivering the service get additional training on how to deliver that course. It was accredited with the CPD accreditation. I'll find the link. It's gone from my brain at the minute, but yeah, I think CPD service, they said.
The CPD accreditation service. That's today's session will also be accredited by them for knowledge for everybody. Well, you'll get your certificate hopefully afterwards. Also, Camille, another thing that's come up. Just bear with me whilst I look back in the chat to find it. I just saw it and then I got distracted there. Yes, very important question. How does the role of the voluntary sector fit here with what you're doing?
Yeah, absolutely. I didn't really have time to elaborate on it. So our voluntary sector have helped co-design it all. And that key worker role that you might remember, that's actually the voluntary sector that we've commissioned to have that role. So they are one of the 5 key members of our integrated neighbourhood team, and the pharmacist is funded by the trust. So we have roles in primary. The whole team is within the community in primary care, but 2 of them are funded, one by the trust and one has been commissioned by the voluntary sector.
On that point, do the voluntary sector people who are, so has it been commissioned from the voluntary sector or by them? How does it work? Because often when we talk,
have paid for them.
Yeah, that's such an, I think it's really important to say that out loud, because one of the things that really is frustrating about when we work with the voluntary sector is how we kind of think of them as almost free resource, and they're not. They have to be funded, don't they, to take on formal roles in this kind of work.
I couldn't agree more. And when we all, co-design is such a buzzword right now, but we often just expect people to give up their time for free. So what was really nice is we were able to remunerate all of our people with lived experience who helped co-design our integrated neighbourhood teams. And I think that's really important, and it's a really good thing to really strive for. So same with the voluntary sector, as this role, definitely this is a paid role from the ICB.
Yeah, I mean, it's an NHS England good practice to pay people with lived experience for participating in things as well. So yeah, that's brilliant that you were able to do that. So I'm going to put a car park in to send out some information about training around lifestyle medicine. That's come up in the chat, Camille. So we'll send some information about that. If you pass that on to us, we can send some information out.
And thank you for having me.
I feel like, some of this has been covered already, Alicia, hasn't it, in Cammie's presentation? Yeah. And I'm thinking, we have got a very experienced group, and I'm wondering whether it might be worth you very, very quickly just illustrating like a results board and various things like that. But then maybe we can free up a little bit more time for Rupa and a bit more time for discussion, because we've got such an interactive group today. What do you think?
Yeah, that sounds like a really good idea. So I'll skip ahead and show everyone a results board. Camille touched on this actually. This is an example from a diabetes group clinic. So you'll see, if I get my laser, you've got the optimal ranges at the bottom there of each individual patient, which their names are on the left. And then you decide which markers you want to have at the top of your results board, depending on your patient cohort, which kind of data points you want to measure and compare. And this would be on the screen like it is now if you're doing a video group clinic, or you would use a whiteboard or a flip chart, for example, if it's face to face. So yeah, this is a results board. It's really helpful to get the patients to look at their own results, compare it to the optimum, and they can see what other people's are as well. So they can really, reflect on that too. You can also use a topic board to help structure your conversations in a group clinic. So this has come from a menopause group. So you've got things on there like aches and pains, bleed pattern, fatigue, etc. And again, you decide what goes on here to help you structure those conversations. Some teams like to use a combined topic and results board so that it's all on one slide and you're not having to move around with your slide set if it's online, and you can replicate that on a whiteboard or on a flip chart as well. Okay, so I will welcome Rupa to the webinar now, and I'll let you introduce yourself, Rupa, if that's okay. I think I saw your name pop up. There you are.
Hi,
Welcome.
Alicia.
Over to
Thank
you.
you. And I was just watching the end of Cammie's presentation there, and absolutely amazing outcome data. And it just goes to show what, using lifestyle medicine with the group clinics and how that combination can really make such an amazing impact on those patients. So yeah, fantastic. My presentation's more of an overview, but in the discussion, I'm really happy to answer any questions about what we do in our practice. So at the moment, our group clinics are around, we have a healthy heart clinic, which is lipids and blood pressure. We have a weight management clinic because at the time of the GLP-1s, we had so many requests for going on GLP-1s by patients that weren't eligible. So we just started that off, and we thought, well, if patients are activated and they want to do something about it, let's get them in. So we do that as well. We've got a chronic pain, stroke, fibromyalgia cohort as well that we also do. So yeah, there's lots happening, and every other Wednesday evening for our extended hours, we do our menopause group clinic as well for the PCN. And really happy to help and answer any questions about that. And I think group clinics is literally all lifestyle medicine, isn't it? It's about personalised care. It's about asking the patient what matters to you. And it's bringing in those skills about the coaching, as Camille said as well, and Alicia has said as well. Next slide, please. So yes, I'm going to go through lifestyle medicine, and I'm not sure if Cammie's already gone through the BSLM principles, but do tell me if she's gone through these already. So I also work at the BSLM, so I'm transformation lead, but I have another role. I'm a GP in Berkshire West, and I'm also deputy medical director for primary care in the Southwest region. And one of my national roles is National Primary Medical Directorate lead for group clinics. And I'm really passionate about group clinics. I've been doing them since 2018 through the pandemic as well, to get through to our patients. So the BSLM really talks about the principles of lifestyle medicine in three different ways. So these are our principles. So the first is always think about the patient's personal circumstances. What are their social determinants? There's no point pitching something that isn't going to work, particularly on budgets or geography and time for the patients. If they're working 2 jobs, and they're a single mum, etc., there's certain things that are not going to fit in with that person's lifestyle. And what can we do with the surrounding community to help some of those social determinants, and who can we link in with in our integrated neighbourhood teams, social prescribers, health and wellbeing coaches, housing, councils. So how can we really holistically look after our patients? And the second is the skills to support. And that one of those is group consultations. Other is health coaching, social prescribing, some CBT. The BSLM provides some resources on our website, which I've developed on how you set goals with patients, and also how to take a lifestyle medicine history, all free. So just go on the Lifestyle Medicine in Practice page on the British Society of Lifestyle Medicine website, and you can have a look and download some of those as well. And then the lifestyle pillars, the 6 pillars, and I think Cammie's gone through them as well. So look at the patient in front of you. What are their circumstances? What are the skills that you need? And then go through each pillar with them. And as Cammie said, you don't want to overwhelm patients. They choose what is that matters to them to focus on as their goal. And as they improve and then they feel better, they become empowered themselves and they want to look at the next goal. What can I do next? Which pillar can I tackle next? Bringing in their friends and family, of course, their support networks. And these are the skills that I talked about to transform care. And I would recommend that having a health and wellbeing coach in your practice, or looking at using the skills through your PCN, through your neighbourhood teams, to having people with these skills. They don't necessarily need to be a health and wellbeing coach. We could get skilled up in doing some coaching ourselves. And I actually did my coaching course having been a GP for probably 18 years already. And once I'd done my coaching course, I thought, what have I been doing all this time? It completely transformed the way I consult and the way that patients leave my room. And I know that they're going to take on some of what they're doing. And particularly for group clinics, it's an invaluable skill. And I would say that everybody in the practice should have some of those skills to do coaching and motivational interviewing, and particularly on person-centered care. Next slide, please. So how can we embed lifestyle medicine using group clinics? Please, Phil, there's 2 more. So using group clinics, we can deliver behavioural change, we can deliver social interventions, we can do shared decision making and motivational interviewing. And I think it's really good to actually use the power of the group as well, because the influence of other people feeling the same as you, having the same condition as you, and then grouping up and going for walks in the park, going to over 50 swims, as some of our patients have done. So you're much more likely to do something and put your mind to something if you've got someone to do it with, and that's where some of the the peer networks really come into play. And the personalised care, what is it that matters most to you? Not what matters to the clinician, but what is it that matters to the patient? And support that group wisdom, get the patients answering their own questions to each other, and you can facilitate that. And the beauty of group clinics is you can bring in voluntary sector, you can bring in your multidisciplinary team, you can bring in a secondary care consultant, you can bring in a mental health practitioner, you can bring in talking therapies, you can bring in specialists, physios. So you've got that expert knowledge around this patient group that you can really embed some of these lifestyle medicine principles and skills. And then how do you choose your group? You can keep it open, you can send patients links to book in themselves, or you can use your population health data and choose a targeted approach. Who is it that's going to benefit most? Is it people with the highest cholesterols? Is it people that have been in hospital a few times with long-term conditions? Is it people that have got multi-morbidities and you can do them all the multi-morbidities at once, like a CVRM clinic, for example? So how do you get the most impact for the time that you're going to put through this? And also, could you do this in a different language? Do you have people in or doctors or nurses in your practice or allied healthcare professionals that speak different languages so you can really tackle the health inequalities? Or can you go out into the community and run some of these? Can you do them virtually? We did Keeping Healthy during Ramadan for our mosque population because they asked us, they said, we really eat very badly during Ramadan, really unhealthy foods when we break our fast. Can you give us some advice? So we ran a clinic for them. So what is it that your community wants? Go and ask them, what help do you need? And then you can tailor your support. Next slide, please. So this is just going into policy a little bit of group clinics and their 10-year plan, and how group clinics can really deliver those 3 shifts: hospital to community, analog to digital, and illness to prevention. And I think in the neighbourhood frameworks, etc., that we've got now that people are working towards, group clinics really tick all the boxes for me. They are the vehicle for integrated neighbourhood teams. Next slide, please. And on the next slides, which you're welcome to have, I won't go through them all just because of time, but we have all the studies, we've got the evidence, we've got the impacts. So group clinics, it's all evidence-based. There's so much evidence out there, but they've been going on for many years now, that if there's something that you're thinking about doing, no doubt there'll be some kind of pipeline of evidence that somebody else has done. So let us know, we can help you with some of that. And it's a good way of showing data to really influence your practice, your partners, other members of the neighbourhood team to come on board with it, because it does work. And we saw with our own eyes, didn't we, of Camille's amazing HbA1c reductions as well. So I chair a national NHS England task and finish group, which has lots of different members from different avenues, some from NHS England, some from outside, and really looking at nursing workforce, workforce training and education, data analytics, behavioural sciences unit. So everybody that we could get to come and join our group, we've got to come and join our group, including external partners like the British Society of Lifestyle Medicine, like PCI, Health Watch, Health Innovation Network. So anybody who's involved in spreading good practice, spreading an adoption of what works best for our patient population, we've invited along. And we have written 2 policy papers. The first is how to deliver the 10-year plan. And then the second one is on neighbourhood group clinics. And you are very welcome to have a copy of that, but it is draft still because it's still sitting in NHS National Comms. But if you're happy to know that it's only in draft, please you're very welcome to have a read of that. And it again talks through all the evidence base around neighbourhood group clinics. And ELC are also on that group. So I really just wanted to talk a little bit about neighbourhood health. The principles are really using your population health intelligence, using some of your tools that you may have in practice, segmenting your population, finding out what's going to make the biggest impact for your population, using your risk stratification tools, which many of you will have, such as Brave AI, the John Hopkins tool, any of those. But if you don't have the tools, you can still do your searches through your System 1s or your EMIS. It is absolutely possible. And invite those patients that it's going to make the biggest difference to. If you're just starting out, just invite patients and practice on them. People that will turn up, people will participate. There's no harm in that. Start small and build yourself up. And invite your system partners in as well, your community trusts, your health visitors, your midwife team. Invite them all in. It's a really exciting opportunity. And I haven't been turned down by any of these people because they're always interested to understand what's going on, how do we get involved, what can I do to help. And when we did our postnatal group clinics, we also invited the breastfeeding network, and that was fantastic because so many children with feeding problems at the outset that they can give fantastic advice to. And why now? Why is it important that things are shifting? Because if you think about how many practices are now doing group clinics, or how many practices are now, actively practicing lifestyle medicine, it is a movement, and it's impacting on access, waiting times, reducing waiting lists. It's improving care for our very complex patients. And I think most importantly, it's making us more into a team. We're no longer working in silo in our rooms, for 4 hours and then coming out for a coffee break or nipping out to see what's going on in the waiting room. And we are actually working together. We're learning from each other. We're listening to how each other consult, and we're learning from our social prescribing colleagues, our health and wellbeing coaches, our pharmacy team, and we're learning about how they influence patients to change, how they motivate, and we're creating that time, which is really important for prevention. Otherwise, what are we doing? We're just, getting people out from the bottom of the stream. We're not going upstream. We need to start adding in that prevention lens into all our consultations and what we can do. And group clinics is an ideal way because it is all about lifestyle medicine and prevention. And we have also had some evidence from the health economics unit on the productivity gains as well, on access and finance and the system as well. And in my practice, certainly, we have noted when we do our menopause group clinics, for example, all our patients get put in if they do an online consultation about the menopause, or they phone up and ask to see somebody about the menopause, they go straight into the clinic. That opens up more appointments for other people. Similarly, when we're doing our blood results for our lipids, they go straight into our healthy heart clinic. If our pharmacy team, a community pharmacy doing the blood pressure and hypertension service, contact us and let us know that we've got high blood pressures, we put them into our healthy heart clinic. So we're actually putting our patients into the right place with the expertise that is there with other patients, so they get a really good service from the outset. And the same can be said of our chronic pain patients. What we've noticed is we don't make them deprescribe, but they are coming off their meds, and they don't consult the GPs as much because they've got how to manage their condition themselves. I think that's my last slide. So back to you, Alicia.
So we have got a few questions for you, as you would imagine, Rupa. So I'll just run through these. So one question that people always ask, I know I'm sure you've been asked this before, is don't people feel exposed or embarrassed to have their biometrics shared? So how do patients respond when they get to compare their biometrics with other people's?
Yeah, I think this is something that we worry about a lot because we're all, it's been ingrained in us that confidentiality. But if you go out into the waiting room, 9 times out of 10, somebody will be telling the receptionist about something, and they don't mind. They want to share, and it helps them feel less alone. So I don't tend to put weight on my results boards because I just feel that that maybe people don't want to do that. But things like blood pressure and their last cholesterols, it gets them speaking, it gets them talking on their last conversations of how did you manage to get it down, tell me what you're eating, and it just starts the conversations off. And in practice, people don't mind. You ask them, is that all right? And by all means, you don't have to share if you don't want to. But once one person says, oh, I don't mind, most people just say, actually, I'm really happy with that because I want to know what other people have got, and I want to know where I am. Because in a one-to-one, it's difficult to rank yourself, to know, am I good?
Exactly.
Am I not? What do I need to do?
Yeah. So it is one of the sort of tenets of behavioural science that people make sense of the world by comparing themselves with other people. And I think that's what you see in a group clinic, isn't it? That you basically people suddenly get a shock because they didn't realise, even though the clinician's been telling them your HbA1c is going up and up, when they see themselves in the context of other people with the same issues, it's a revelation, isn't it, quite often?
Yes, yeah, absolutely. And it does help them manage their condition. So
well, you can't manage your
them.
condition if you don't think you've got a problem,
if you don't
can
know.
you?
Yes, absolutely. If you don't
that's
know
the whole
there's
point.
a problem.
Yeah, if you haven't had that moment of clarity that actually I'm a bit of an outlier here, because the natural thing people want to do is to be like other people, generally speaking. So that it gives them that motivation. So I think that was the only question that we had. I don't think we had any other questions. If anyone's got any other questions, it would be brilliant for you to pop them into the chat now. I just wanted to add a couple of a little bit to some of what you said earlier. The slide, I don't know if we can go back to it, Alicia, the one where you had the sort of 3 elements of lifestyle medicine. So talking about personal circumstances, skills and lifestyle pillars. I just thought it might be helpful to just set out how those are dealt with in a group clinic. So in terms of that kind of personal circumstances that you can't control them, but that is the sort of thing that you would discuss in the one-to-one part of the group clinic, isn't it? You would definitely kind of go into that with people. So if they say things like, I'm really struggling with money right now, I'd like to eat more healthily, but you know, the bills are mounting up and I'm finding I'm just reaching for the cheap stuff in Iceland, that would be something that you could kind of, you know, deal with in a one-to-one.
And often other patients, you know, start sharing recipes and things like that with each other and saying, you know, these are really, or I've got a really good recipe book for budget meals. And, you know, people start trying to help that person and giving them ideas on where to shop and how to work better on a budget.
Or food banks and things like that.
Absolutely.
Like, you know, have you been to the food bank? I'm the same. I'm in the same situation. I know it's sometimes you're embarrassed, but if you want, I'll take you to the food bank or whatever. And you facilitate that as the clinician by encouraging them to kind of, you know, has anyone got any ideas and that kind of thing, using your coaching skills.
And I also think that, you know, if you haven't done group clinics, you might be thinking, gosh, you know, I would never divulge something like that. I'd be far too embarrassed in front of a group. But the aim of the group, you know, is to create that psychological safety. It's all about making people feel welcome to be able to talk about what they want to talk about. So, you know, we've had people really emotional, we've had people crying, we've had people talking about their bereavements, but it's about creating that really safe space. And you may think, oh, I wouldn't do that. But actually, once you create that safe space, people do share, and they share willingly, and they share in a way that you know, empowers other people to share as well. And we set it all out at the beginning saying, you know, whatever is said in the room stays in the room, etc. You know, we make it a safe space for people to share.
Yeah, absolutely. And that's part of the process. So there's sort of 2 ways in which group clinics work, and the 2 things that make the biggest difference to the outcomes for the patients is being true to the process, a tried and tested group clinic process in just the way you've described, Rupa, and also being a really good participatory leader of the group, so getting the patients to talk, that rather than you giving them the answers to their questions. And I just also wanted to flag on that the lifestyle pillars make a great topic board. So earlier you saw the topic boards that Alicia shared, and just think of that, like putting the lifestyle pillars on that topic board gives you a great way of integrating lifestyle medicine into any group clinic, really, for any long-term condition. So that's just some thoughts to share. We are running out of time, and we've got a few more people have posted some questions. So one of them's from Alex, who said, what would you see as being how the session would split between a clinician and a health coach time wise? So maybe you could give us a little thought on that one. And also Laura said, do you always need to have a clinician in the group for safety?
Right. So what we tend to do is our health and wellbeing coach does the facilitation as well. So he would welcome everyone in, set the scene, do the group rules, and he would do the goal setting as well at the end. So the clinician does the middle bit. But it tends to be a conversation. It's not a kind of you speak now and then you speak, you know, everyone chips in and you talk like a conversation. So that's what it is, really. It's like a structured conversation with the patient in the middle about what the patient's needs are. And no, you don't always need a clinician in the group. So what we tend to do is, say, for example, we had our social prescriber took a group on sleep, and he did that on his own. But he knows that I'm only next door, and the facilitator can come and get me at any time. So if you've got somebody in the building, that can be called upon. So if you want to do something, for example, in extended hours on a Saturday morning, you've got people around. And our pharmacists sit in our Healthy Heart clinic with our health and wellbeing coach. But our health and wellbeing coach actually runs the weight management clinics on his own because he's got a nutrition qualification anyway. But we do have doctors on site at the time if there's anything that they need. They just get somebody.
I think actually it's really important to have good kind of supervision, isn't it? Even if you've got, say, clinical pharmacists or nurses
Yes.
or anyone else, you know, you want to make sure that you have a little system of kind of clinical supervision built in. That's really helpful.
Yeah, we always do the
very aware
feedback
of
at the end. You know, always feedback and go through any concerns as an evaluation, and go through any clinical safety concerns, which we don't really see those, but if it's good for governance.
Absolutely. So I'm going to hand back to Alicia to bring us to a close so we finish on time. And I'm going to pick up with Bridget's question in the chat because I think that might be aimed at